So the first thing that we'd like to do is some check-ins and introductions. We're interested in what brought you here. Why were you interested in this discussion? We'll introduce Percept and the Bertha Centre if you don't know of us already. We'll have some group discussions and hopefully come up with some key takeaways. And then we'll close out. Some of the next steps, and I'll reiterate this right at the end as well, is the learning briefs were published today, correct, Anya, on Percept's website?
Actually, yesterday.
But, yesterday?
Yes, let's say today.
Congratulations. Let's say today, and it would be great if you all could share that, if you feel moved to do so, because they're a great piece of work and it would be wonderful to have them shared widely. So what I will go to is just check-ins. We'll do a round robin of check-ins. And if you could maybe in one word or one sentence, just share with me what brought you here, what are you curious about, and obviously your name and where you work. So I'm going to start right at the top of my screen. And unfortunately, that means that you're in the line of fire, Siraj.
Sure. Can you hear me fine?
Yes.
Okay, cool. Siraj Adams. I'm from ES Health, which is a last mile logistics business. And I also run a company called Digital Health, which does telemedicine development and software. I'm just curious to find out more about the findings of the work that's been done and see if there's any way that I can collaborate with various partners. Thank you.
Wonderful. Thank you. And now I'm going to go. And Andrew, I'm going to pick on you because I see you just joined. And what we're doing is introductions and what brought you here? What are you curious about this discussion? Just one word or one sentence.
Sure. Thanks. Sorry to join late. Juggling
no,
calls. Yeah, it's great to be here. So Andrew Carlin, I'm with Living Good. I'm very curious about the linkages between facilities and communities for digital health. So that's my main area of interest.
Great, thank you. Leah, I'll go to you.
Hi, my name is Leah Wanaswa from Triggerize, the program's lead, representing Jesse, who was meant to be on here, but having gone through the various articles that were shared, I'm curious around areas of collaboration in this digital space.
Thank you. Emmanuel.
Yes, thank you so much. My name is Emmanuel Ahumza from my Social Innovation and Health Initiative, Uganda Hub. I'm curious about the best practices in the models, and I'll be glad to join the discussions.
Thank you so much, Emmanuel. And nice to have you join us, Barwani. We're just going around doing introductions and sharing what made you interested in joining this discussion today and where you're joining us from.
I don't know if you can see me. Okay.
Yes.
Okay, right. So if you see people around me, just ignore them. So I'm from Malawi. I think for me, what's interesting is because we're looking at primary care and technologies that can decongest them. And I think with COVID or just normally the health system, we always say we're doing a lot for healthcare, but we're not really pushing quality. And with also technologies or innovation, it's overburdening the health system than helping at the end of the day. So I think for me, the interest was to say now that with COVID, we've had to accelerate or really step back to say, are these things really helping? So I think for me, that's interesting to see maybe those linkages or similarities or things and how those are really working in practice with the pandemic. So for me, that was interesting, but I think around it, and also because we do work around it. So it's definitely an interesting topic from my end. Thank you.
Thank you. Shivani.
Hi everyone. My name's Shivani Ranchard. I'm the CEO of Percept. So excited for this conversation. I'm interested, curious, I think, always from two perspectives, like from a bottom-up perspective to really understand, I guess, what drives organizations to be innovative, and especially in our context. So, how do we find ways of nurturing locally relevant solutions? And then also interested from a top-down perspective, from a systems perspective, and what is it about health systems that either helps innovation to thrive or stands in the way of innovation thriving?
Okay, I need to go get my laptop.
I always think it's great to have multiple perspectives, and I think it's interesting that we've got people from an entrepreneurial space, academic space, NGO space, just to be able to share different ways in which we can work together to actually make some of these things stick.
I'm Debbie Rogers. I can't read meeting invites, but I'm the managing director of PrayTel.org, and we use simple mobile technology like WhatsApp, USSD, and SMS to empower patients, support health workers, and provide the information and services, the information to health systems to improve the health system themselves. I think what really interested me in this is that there's been a lot of research around whether or not messaging can be used for behavior change, or whether or not there is any point in speaking to this person or that person in the system and what it actually brings. Very little, in my experience, certainly has been spoken about with respect to how you can make sure that health systems are used for what health systems need to be used for, and digital health can relieve that burden by providing other elements of support. Digital health in no way should replace a health system, but I think that it has uses beyond just sending people information or gathering data. And I'm very interested in the conversation around this today as a result.
Great, thank you so much. And then I'd like to quickly go to Aisha and then Anya, please.
Hi, everyone. Thank you all for coming. I'm part of the Percept team that helped work on the innovation work. So I'm very interested to hear about everybody's unique learnings and how it can be used across everyone's platform.
Great, thank you. Anya.
Yes, thank you, Katusha. I'm Anya Smith. I'm an economist at Percept, and together with Aisha, we wrote many of the briefs that have now been shared. The one word that best sums up what brought me here is impact, because I think in living in South Africa, I think we're often very constrained in the way we view the world. And I was very excited to go a bit beyond South Africa to learn from the innovative models and approaches using technology to decongest healthcare facilities.
Thank you so much. And again, thank you everybody for joining and looking forward to the discussion. I'm going to turn it over to Anya for the next few slides just to give an overview of the work that Percept has done and the learning briefs.
Thank you, Katusha. I think you can go to the next slide. This particular slide really just speaks to the different themes we wanted to address in our series of 5 briefs that are now available on our website, looking at the different ways in which technology or really digital tools are being used to either better link communities to healthcare facilities or to better serve existing health needs in a digital way. And our brief series is very much focused on the primary healthcare level and on the ways in which the digital tools can alter the patient journey. I think in often also making access to care much more convenient, affordable, easy to patients. And as I mentioned earlier, I think we purposefully tried to not focus on models in South Africa, but to actually do a scan of what we believe are the most interesting and exciting available models in sub-Saharan Africa. I think what we're trying to achieve through this brief series is really 3 things. The first is just to make people aware of the different models and approaches that are out there, but also I think the challenges they've experienced in often getting to scale or getting to a level of sustainability. We also want to really provoke conversation and debate on the deeper challenges around truly embedding technology in the way we deliver primary healthcare and what the limits are to technology in trying to provide human-centered care. And lastly, I think from this group today and from our conversation, I'm also expecting some deep thinking about what is required next from a systems perspective. Now that we have these interesting models, we've documented some of the lessons. If we really want to make this part of health systems and not only keep these models at quite a localized or contextual level, what do we require from policymakers and regulators? And I think the people in charge of creating more enabling environments for innovation. So I thought it would be good to just say something about all 5 of the briefs and what they cover. We're not going to go into deep content. So the first brief really just sets out a framework for thinking about the language and categorization of the different models. And it's in a way an overview of the issues and the available examples that we found in sub-Saharan Africa. In the second brief, we take a deeper look at the ways digital tools can empower community healthcare workers in Africa. And there we specifically focus on Living Goods and their smart health app and the upscale experiences. In brief 3, we looked at telehealth innovation in Rwanda. where we documented the lessons and insights from the Babel experience. And I think as far as I know, that is really the example of telehealth in sub-Saharan Africa that has been taken to the greatest level of scale. In brief 4, we look at mobile health innovations in patient self-management. And Leah, we're very, very happy to have you here from the Triggerize perspective. So Triggerize is one of the models covered in that brief. In the last brief, we stand back from all these models and our documenting of the experiences and lessons and insights and ask the question, what enables and constrains digital healthcare innovation in sub-Saharan Africa?
Thank you so much for that overview, Anya. And I just quickly want to give an overview of the Bertha Centre for those of you who don't know us. We're an academic unit housed at the University of Cape Town's Graduate School of Business. And we focus on research, teaching. We teach MBAs. We're actually the first MBA, I think, in Africa that requires social innovation to be a part of the module. And we do a variety of different executive education courses. We also focus on dialogue and convening, such as this one, which we hope will form catalysts for change and as well as advocate for transformation. So our mission is to really build capacity within Africa around social innovation and what that means. We've been around since 2014. We very much used to see ourselves as a startup, but I think in startup years, we're now probably an adult. So we have to start moving beyond that. We have a number of different portfolios, including innovative finance, education innovation, youth development, and systems work and social justice, as well as health systems innovation, which is the portfolio that I lead. And we do believe that social innovation in health is a mechanism through which we can move closer to achieving health equity. And we like to look at it through the lenses of accessibility, affordability, and acceptability. So this very much fits in with understanding and researching how health systems are changed, as well as creating and promoting spaces for social innovation and health conversations like these and dialogues like these. So we're thrilled to be a part of this. Looking forward to delving into the conversation. Because there are just a few of us, Anya, if you don't mind, I think we'll stay together in one group. And these were the questions that we were interested in having some discussion around, or to at least initially guide this discussion. What are the improvements to the system that digital tools can create? What business models have been most effective? And how can the benefits of digital healthcare be best communicated? So these are really just a starting point for what I hope will be. Anya said that you wanted me to be controversial, but maybe I should wait for the rest of you to share your opinions and I can get in from the side. Just looking at this, would anybody like to kick off the discussion as to what is a burning issue that you'd like to address, guided by these questions? I'm also not shy to cold call on people, so.
Do we have to stay in the order of the issues?
Of course not. No, this is very freewheeling, not prescriptive at all. And if you have an issue that isn't even on the page in front of you, then let's talk about that as well.
Sure, we need multiple pages there. But one thing I apologize, I read a few weeks ago when the initial drafts came out, so I'm a little rusty on the details, but I was interested in the Babel example from Rwanda, and particularly it's a fee-for-service model, and they've managed to get to a fair degree of scale there. And I'm wondering where the fee structure, a business model with a fee structure to the client, have really come into play, and if there are opportunities around that across different solutions.
Just to add to the question from Andrew, is Babel 100% sustainable? Meaning, is it 50% subsidized by Gates or USAID? Just to confirm whether or not there's any subsidy by an external funder to support it in the country it's being applied, or is it completely self-sustainable and the population that's using the platform is paying for the services? And if the government is subsidizing the services by Babel, is the government being subsidized by USAID or Gates?
I think just to add to that, I think it's also important to look at the context of healthcare in general in different countries. in South Africa, we have 80% of the population dependent on completely free healthcare. So does that mean that the digital services around that also need to be free in order to, to match the healthcare model? And is it in different countries where people may be used to paying for healthcare, is it going to be different to be able to make something sustainable? I think that's another important contextual thing to look at when it comes to business models.
So I could add a tack on another issue, perhaps, is that, and perhaps be, I guess, linked to issue 3, is that, one of the challenges we see in the public system in Kenya, Uganda, elsewhere, sure, is that providers are very interested in quality improvement tools. There's many disincentives to adopting them, and both understandable and some kind of perverse, right? It competes with the existing model. There's also a trust barrier, I think, in adoption as well. So I'm curious to the extent that when we look at stakeholders, we look at it from that utility perspective, what they're willing to adopt and what they're not. And we even see that in confidence in the data that are being entered in EMR and other systems, where the providers themselves don't fully trust the data in the EMR because they know themselves what they put into their own EMRs. It's a bit of a contradiction there. So there's a hurdle there that we haven't really quite overcome. And I'm wondering if the digital models really address that.
I think I think that point about incentives is a really important one. And I think that's where the health systems perspective is so useful, right? To locate the solutions within a broader system and understand what the dynamics are that exist within that system and what drives behavior. But I don't think it's a digital only issue. I think it applies to pretty much any intervention or design change that you make in a healthcare system. I guess the tricky thing for digital is that it adds to the layers of things that you have to think about, the regulatory environment, the digital readiness, but then also, how does this actually play out in terms of behavior and use of whatever the solution is?
I completely agree. I just know as a digital provider, I often catch myself thinking of digital as a good unto itself, which it is just a tool. And so, but I'm constantly reminded that that's not always the case. But I completely agree with your point.
Andrew, I think one of the things that I think can help with this issue of reliability of data is to try and get people who have the least disincentive, let's put it that way. No one's going to be completely unbiased, right? But have the best incentives or the least disincentives to be able to respond. So, for example, asking, small example, MomConnect picked up stockouts before the stockout systems did, because pharmacists don't want to log that they have a stockout issue, whereas mothers are very happy to do so because you've told them to go and get a medication and they can't get it. So it's not a solution just to make it all citizens, but to make sure that when we're asking for this kind of feedback, we understand what the incentives are around that and try to make it as well, not, what is the word? Not as disincentivized, or whatever that phrase is that I'm looking for, with those people specifically.
Yeah, great point.
Leah, from a triggerized perspective, what are your thoughts?
No, I think as we are keen to move now into the space of public sector, I think the conversations around bubble are really what we are looking at as to how we would, for example, incentivize or get public system providers motivated to use our platform, and what that took. What was the in-ground processes that went into that to get them to take up the platform and take that as part of their normal work mechanism? I think that's where we are driving our curiosity right now. Yeah.
And what are some insights from that?
So one of the things that we have really taken into consideration, having done a lot of the work right now in the private sector, is the buy-in that needs to be established, first of all, from the national system and now at the county government. Now, this is applicable for Kenya, in getting them to adopt the trainings that we are going to put in place, and also practice in the in-person sessions that we'll be putting in place, which we are hoping and trying to test in a few weeks to come, hopefully to see how they would adopt and start use of the platform as another alternative means to what they are doing. So that's sort of where we are at this moment.
Aisha, if I could ask you to chip in, maybe from the Babel perspective, because they had a different experience to triggerize in Rwanda.
Sure. So just to go back and address the initial question of Babel and the financing, I can't speak for them currently. We had spoken to them at the end of last year, but at that point, the services provided on Babel were 90% funded by the National Health Insurance. And this was largely due to the fact that the Ministry of Health was on board from the get-go and invested in the tool. And patients are requested to pay 10% of the fees. In terms of the getting buy-in, as Leah said, this was also a struggle that they did face. And I think there are several things that they ended up doing to get that buy-in, where they initially started off with plain marketing, which wasn't in fact working. And not just getting people from the general public to use the service, but also from a healthcare provider perspective, getting providers to trust in their service itself. And so they did two things that they had mentioned to us. The first being that they changed their marketing tactics so that they would target people directly in their homes and have conversations with them so that they could get buy-in. People were attending facilities and they were asking individuals to be registered while waiting in line, and kind of incentivized them to sign up just because the waiting times were quite long. And then from a provider perspective, what worked quite well is that the call centers are recruited members of the public healthcare system. And so they work in both the Babel call center as well as in other practices. And this created a sense of trust between the providers in Babel and outside of Babel.
Great, thank you so much. And, I'm going to pick on Dr. Nedson as a representative from government to maybe get his perspective on what it's like to be on the other side.
Hello, can you come again? And my apologies, I joined late because...
No, not at all. Thank you.
My network is very unstable here.
I was picking on you as a representative from the Malawian Ministry of Health to find out what your perspective was in working with Village Reach and pioneering Chipatela Chapafoni as being a part of the national program, and what it's like to be on the other side of, working to integrate these solutions with government.
Okay. Now, in the first place, Chipatela Chapafoni was relatively easy to work with the Village Reach because I'm sure you might have mentioned some of the challenges in the health system might have been highlighted already. Malawi is not different from other African countries in terms of the challenges in the health system. So in trying to deliver essential health services to all the people of Malawi and trying to point towards universal health coverage, that we don't have to leave anybody behind, the rural areas are not well serviced. We have got poor road network and very few health facilities, few healthcare workers. So maternal mortality and child mortality is something that is a big problem also in Malawi, though it has been like on the downward trend in terms of maternal mortality, but still the numbers are still very high. So the government of Malawi, through the Ministry of Health, in trying to improve that, it was just a matter of challenging now the corporate world, the system, the stakeholders. So how can we make improvements with this problem? So together with Village Reach, the general public was reached with that question. It was advertised in the paper, and people were proposing to say maybe we should do that, we should do that. So this digital solution came in and it was tried in one of the districts, only to be found that it works very well. Because people out there, some of the health problems that we have, the people just only lack health information so that they can participate in their own health. So in trying to give the people the health information, the digital tool was provided to the people in one of the districts as a pilot. It was like a call center, people were calling, and also there were some recorded messages. People could call the call center and listen to the recorded messages. And there were also some follow-ups. They have been given some instructions or advice. The call center people, since they were healthcare workers, they would follow up to those numbers. So people would register to that call center. So it was found to be very, very useful in that district. And then it was scaled up. Now it is, with the coming of COVID, it has become a darling and a very accessible tool to all the people to call or to learn more about COVID. So it was not difficult because it was the wish of the Malawi government or the Minister of Health to try other innovative means of delivering health services, not only looking at patients, but also looking at the health information that is very vital in delivery of healthcare, so that we can have the communities participate in health delivery services. I don't know if I've covered what you wanted me to cover, but
that was great. Thank you so much.
Very exciting. Yeah, thank you.
It is exciting. And I think it sounds strange to say it, but there are opportunities that are posed to innovation when there are these massive systemic shocks to the system, whether it's COVID-19, whether it was Ebola in Liberia, changed the way the government thinks about community health work in that country, for example. You know, whether you're thinking about issues that you've all brought up, such as lack of guidelines, lack of enabling information, lack of investment, of the funding issues that you were discussing, Siraj, there are opportunities that the time that we've been in right now are posing. Shivani, I see your hands up.
Yeah, just part of what I heard with Dr. Fasika speaking from Malawi is that, I guess, the role of leadership, right? So, you know, having leaders who have this orientation towards the importance of innovation and a willingness to partner and experiment. I mean, it'd be interesting to hear sort of experiences from others from other countries, you know? So when we talk about government buy-in, it's not necessarily this thing of like engaging with some sort of mammoth bureaucracy, but also about individuals who feel very strongly about things. I'd be interested to hear from Debbie about some of her experiences with Mom Connect and the South African government. But, you know, I think those ambassadors or champions from within government play such a crucial role actually to sort of enabling change.
You're exactly right, Shivani. I think we all fall into the trap sometimes of thinking about government as a monolith, as opposed to just it's made up of different people, and it really is so intensely relational sometimes. So Barawani, I see your hands up, maybe you and then Debbie.
So just adding on, I think, to what Dr. Fosiko was saying, there's also the issue of when transitioning to government, the issues, I think sometimes when we're looking at these platforms or interventions, we sometimes forget that there's more than just the delivery cost. So if you're going to take it up, for example, if it uses mobile providers, if your network provision, the connectivity is low, people have to pay for it. Who's paying for it? Like in the case of Badajaba phone, you have people who have to cover those phone calls to pick up the call congestion. How is that payroll sustainable? Is those guidelines there? Are you going to talk to the regulators? A lot of these things had to be created. And I think from the Malawi experience, it was also looking at how to engage private sector long-term in a different way, because this is supported by a private mobile provider that generates all costs, and it would never work if they never did it, because that's a very big cost of the platform. And then there's also been a lot of multi-sector partners who've come in and come out. But of course, the issue is long-term. And I think this was what was key also to say, as government took over completely, how is government maintaining that? Even if there's a gap, can government say these numbers of payroll will pay for the rest of these years? If you're moving beyond it, it's part of the health service packages, but who's going to link it? And as you said, actually, even COVID happening, got greater buying across the lines, because when government wanted a first point to stop over and people, were panicking with COVID, they were like, wait, we have a platform we can just adopt, which also strengthened those acceptability lines that people had been engaged. But now people are like, okay, it's more useful than just for what it started for, because it moved from maternal health to everything in health. So now also even the buying, everybody's like, okay, maybe we can give it more of the government funding, more of the line. Yes, we have private sectors, we have donors, but we know that those things can change. And now if it's part of the government, you do want that ownership. So I agree that as much as we're talking private and we're talking other partners that exist, I think it's also saying, but if it sits with government, can we make sure that, example, if a champion leaves today, is it in the system enough that no matter who sits there, when the budget line comes, it has money? So even when you're going to the private funder or your academia who's helping you with research, evidence, tweaking it, all you're doing is changing. And I think one question I'd like to pose to everybody, with all the success or gaps you've had in similar platforms in your country, can you really say that your platform, let's say if it's at national level, what is really the thinking or how it works at district and the community? Because sometimes it starts so well, but when it scales up, you miss a link. So you have a divide that we see, then you have to go back to fix that. So I just want to know if you've had that happen, or how have you gone back to backstep it? And also, I think a bigger issue that keeps happening in Malawi is that people keep recreating things that have similar use. So now you almost have the health sector, and maybe this, when other people speak, they can speak about, like, from the Ministry of Health or as a health player, you're being bombarded by things that are not the most helpful, but they seem critical, and you're saying, why? So it seems like people, you're saying no to everybody, but because they're not packaged the right way. And maybe how have you navigated those situations as well?
That's such a good point, Barwan. I mean, I think it was Nigeria in about 2015, 2016. Didn't they put like a moratorium on all new...
Uganda did.
Uganda, there you go. So it's a real issue. And, you know, you have to feel sympathy for government. Debbie, and then Dr. Fosiko.
Yeah, I would just, from my personal experience, I would agree with the initial comment that government isn't monolithic, and certainly what we've seen, where we've seen great support within government, has been through individuals who have an innovative mindset, have a vision of getting things done, making sure that the Department of Health can be leading rather than lagging in these areas, are themselves maybe not technical, but linked into what are the technical innovations that are happening at the moment and what could we do to improve that. And certainly we've had some fantastic champions like that within the National Department of Health. But then the problem with champions is if they should leave, then what happens, unfortunately, what can happen is that, particularly if there is some kind of difference in opinion, and that's why somebody has left, or difference in approach, it can actually backfire. So I would suggest to everybody, if you have that champion, you need to try and work with that champion to get it institutionalized within the system, like you say, being a budget line item, all of those things that will make it continue thereafter and not so reliable on an individual. Because as much as I think individuals are incredible for getting things going and getting initial buy-in and then can, you know, sing the praises of the program, if those individuals leave, you could have a 6-year-old program that suddenly doesn't have a champion anymore, and that's not nice.
Yeah, and I think we've all learned the hard way that champions are necessary but not sufficient. And that advocacy comes from an institutional response, and typically a multi-institutional response, which is the case dealing with both public and private sector, dealing with telecoms and with sometimes financial institutions as well as health institutions. Crises tend to focus minds and spur things on, but then the same competing interests often come back, which is what the case was post-Ebola in West Africa very much. So I would challenge anybody who's looked at that closely to see what was left behind after all of the money spent, the investment spent on both technology and non-technology innovations post that. Certainly, health systems were left better off in the sense that there was a focus on what user needs were, but the ability to respond to that wasn't nearly as robust as we all assume. Perhaps not, but perhaps we're all aware of that. I think the other thing is understanding from an advocacy and policy perspective that there has to be ongoing reinforcement at multiple levels, and that both national constituent groups are hugely important, and there are many, and it's very complex, but also regional, sub-regional, and regional groups are really quite important as well. And getting those groups aligned as well is incredibly important in maintaining that momentum that you may have achieved. And a good example from Kenya for Living Goods is that our expansion strategy in Kenya really hinges on government buy-in and co-financing of digitized community health. And what that's meant in the context of what is a quite significant power shift in terms of how health funding is executed between the federal government, the national government, and the counties, is that deconcentration has put both budget allocation and budget release at county level. And there are a number of counties that have been very much out in front in driving towards effective service delivery. At the same time, that didn't coincide with the legal and policy frameworks that allowed county governments to actually spend money going into these public-private partnerships to drive those solutions. So in the end, several counties came forward and matched funds for co-financing of community health work, their ability to do so really sat outside of the legal framework and forced us into a very awkward or ineffectual way of working, which we had to kind of compensate around and figure out different ways and get caught in a public relations issue and so on. This is specifically to Isiolo County. And at the end of the day, as much as there's goodwill to make the arrangement work, the ability for a non-state actor to influence, for instance, quality of care or release of compensation for payment for community health workers or drug supply release has been hugely problematic and no different than in a centralized approach, in some ways worse. So it's not without its challenges as a result.
Thank you. I see we have a number of hands up, but I also see our time and I don't want to cut this short because this is such a great conversation. So I'm wondering if folks would stay on for another 5-10 minutes just so that we can get some more voices and continue this conversation. But I understand if anybody needs to drop off. I'm going to go with Dr. Fosiko and then Siraj.
No, thanks very much. And thanks to Barwani for adding on what I said. To me, I feel like whatever innovations we want to bring in, first things first, and we really need to look at what problems are those innovations targeting to solve. Because if the problems are commonly understood, then we forget about even the buy-in, because the buy-in is not necessary when it is everybody's problem. We saw it with COVID-19 pandemic. There was people coming together, institutions coming together to just fight against the pandemic. So the same thing with this, whatever innovations that we want to bring in, they have to be answering to common problems to all of us. The stakeholder mobilization is something to me that is very, very critical. And once you have got your stakeholders together, as Barwani said, for the Chiparajaba Fund to be successful, it was not only those that developed the innovation, but everybody had already the buy-in right from the start. The donors who are supporting the government of Malawi in terms of delivery of health services, the private sector, you can see Baran mentioned about one of our service providers, cell phone service providers that is also continuing with offering their service to ensure that Chiparajaba phone is functioning. The donor community was very critical that are helping to fund the health system. So if you mobilize all the stakeholders together, right from the beginning, then everything becomes smoother, because whatever problems or challenges that are going to be coming, you're going to be solving them together. And that's the experience that we had in Malawi. We never had any challenge because there was a task team or steering committee that was made up of all the stakeholders every time, meeting almost every quarter, where necessary, maybe monthly, to ensure that the implementation of this innovation is successful. And again, one of the challenges that I want to say, innovations always comes with challenges, because like right now, the training of the people that are working in the hotline is something that is very critical, because the healthcare workers are not trained to be in there. So you need to give them some special training also to develop the human resource and the other resources that are necessary for you to deliver whatever innovation you want to bring in. So maybe without taking much of time of other people can come in to contribute. Thank you.
Thank you. Siraj and Anya?
Sure. I just want to bring it back to the practicality of sustainability. A lot of people mention the word, you look at private sector, partnering with private sector. So I think what has worked really well in our context is that we started public health interventions that was received well in the private sector first, established an infrastructure. So for example, HIV treatment as an example, right? We created a private sector network and then engaged government around leveraging off that infrastructure to service university students as an example. So the biggest challenge that because I sit on various NGO boards, it's all about the next call for the next grant, for the next match funding opportunity. And I always wonder, like the Ebola example, like you put a whole lot of money in from a grant or a donor and there's no sustainability behind it. And I think the biggest challenge with social impact organizations is the general lack of business-minded aspects to digital health. And it's almost the aversion by the inventors around the product, because they care about the product, But when it comes to the pricing model, the forecast of utilization, that's where they fall short. Because they're like, no, USAID will fund us, or CDC will fund us, and eventually the government will take over. Typical of what community health worker model is now. USAID will fund us, and then eventually government must take us, because who's going to do the community health model, health work? So I think when it comes to digital health, if you look at Babylon in the UK, it's a business. If you look at Babel, it's an NHI model, which is not really a business. If you look at a lot of other opportunities, so for example, with COVID, with medicine deliveries, Uber Eats came in and started to deliver patient parcels. And then the question was, after COVID emergency, who's going to keep paying? Whereas Uber Eats continued to be a business. The infrastructure, the resources that are available in a digital environment, such as e-hailing and grocery or medicine deliveries, the tech serves a purpose and it's available for public health interventions. But the problem is sustainability and that business-minded aspect that unfortunately a lot of projects after 6 years will fall flat because that champion is gone. And the funder says, okay, I'm going to direct fund somewhere else. In that 6 years, that's when you should have developed a sustainable private sector or commercial model.
Katusha, can I still
yes,
go?
Of course, please.
I wanted to pick up on a very similar issue as the one just raised by Suraj, and was the one raised really by Suraj and Andrew right at the beginning when we spoke about Babel and donor subsidies and asking questions about the financing model. And I think it's clear they're benefiting from donor subsidies. I think the extent wasn't shared with us. I think it's not really publicly available. And I think in principle, there isn't really a problem with that, as long as those subsidies, as Suraj said, buys the model time to actually show that it is cost effective. And I think either the private or the public health system is willing to pay for it. And I think a really important part of that is pushing the user or patient side and getting people used to, in the case of Babel, speaking to a doctor or potentially even in future a nurse over the phone to discuss their primary health issues. And I think that for many of these models will be the biggest sustainability challenge. Actually getting the users of the model over the hurdle of long-term adoption and making it a preferred way of engagement with the system. I think we often forget the user side. It's all about the tech. How do people engage with it? How do we build it? How do we expand it? But do people, the users of these systems, actually value it? Does it add value to their lives? And does it ultimately change health outcomes? And I think as long as it does, there should be a willingness to pay for it and even continue subsidization if necessary.
Suraj?
Sorry, I just wanted to, I'm not knocking the seed funding concept of getting grant funding. I'm just suggesting that the organizations that are developing telehealth, video calls, SSD services, figure out that model, because I think Anya mentioned it's about impact and value to the clients. And if it becomes indispensable to the health outcomes of a patient, that's very different to a value add service, which is a lot of what gets developed, you know. So it's good concepts, but it's to a large extent, a lot of it is value add. So I think you don't want to get to a point where people say, what has been the impact, the outcomes associated with digital health? Because obviously there's a lot of research needed to prove the effectiveness of digital health solutions. But if you look at what happens in the private sector, you don't invest in a solution if you can't see a return on investment. And I think the balance is between return on investment, meaning does it make a difference, both on the health outcome side and on sustainability side, is important, because I think that discussion on return on investment is to a large extent in the public health, talks about health outcomes and reach and numbers. So if you look at any USAID CDC thing, it's all about M&E, right? How many people did you reach your targets, etc. And the ROI component isn't part of it to a large extent. And there's a lot of new ways of looking at public-private innovations where the private sector infrastructure could be leveraged to benefit public health services. So the new way of thinking around CSI, donor funding, shouldn't be that it should be the project for the next 3 years, pays for admin staff, pays for management staff, flights, conferences, etc. It should be, okay, this is seed funding. We are a startup. How do we get this business to survive once the cash has been burnt up. And that's how most business startups think. And it's about shifting that thinking towards social impact digital health companies so that they can start thinking like startups to become businesses as opposed to I'm an expense cost center.
Debbie, your thoughts?
I think that a lot of donors set up the wrong kinds of incentives for these things. There's always a section in your application, what's your sustainability plan? And you have to tick that box by putting what it is in there. But there's very seldom, how have you reduced the costs of the program per person? What is the cost of the program per person? My question is always, can I go to government and say, you should spend 10 Rand on this versus 10 Rand on a vaccine? I can't, I don't know what that is, right? Until I can say that, until I can say to somebody, it is worth investing 10 Rand into this digital system versus into that physical system, then it's always going to be an expense. And it's always going to be this like expense cost center, as you say, Suraj. And I see very few grants, donors focusing on that, apart from that one thing that you always have to say about sustainability. And there's always the plan to hand over to government at the end. That's always the thing. But, you know, all that you have to do that really is create training material. You know, once you, sorry, I'm being very skeptical and cynical in saying this, but really it's box ticking. It's not asking the questions that need to be asked for something to become sustainable. It's not asking how much is it going to cost per person and how are you going to justify that you should spend this amount versus that amount. Some funders will be willing to give me $2 million to reach 1,000 people, and some people will say, give me 100,000 Rand to reach 1 million people. That's the cost per user is almost never something that's taken into account. It's how many people are going to be doing what and how many Land Rovers do you need to deliver things, which is not useful to us in the digital space. So I think there really does need to be this mindset shift that Suraj is mentioning to these programs. If you don't say sustainable, we're going to hand it over to government, and don't say we'll create training material. There's so much more that has to be done to allow for that. And I'd like to see more donors and institutions investing in helping with building that evidence base that says, this is why this is better than that. It's easier if I say that I have taken, well, relatively easy. I don't want to make it sound trivial, but it's relatively easy to say I've taken this manual system and I've turned it into this digital system. And therefore I can say I'm saving this amount of dollars for this system, right? It's very difficult to say, I have brought in a system that does something that none of the physical systems do. How do I say that that is worthwhile investing in? Because now it's a new thing. And as you said, Suraj, it becomes like a value add, when actually it's something that is intrinsic to running things. We just don't have a good thing to compare it to that says like this thing is better than this thing because of what X. And so we really need to work together as a community and with our funders and with institutions like you guys to say, how do we create this case on a per person basis to say why this should be invested in versus that? Because I look at the South African National Department of Health, all their funding has now gone towards COVID. Of course it has. They didn't have this in their budget. They've had to respond. So what ends up happening? All the other programs fall on the floor and they're suddenly trying to get people to put in money for those things. It's kind of obvious that that kind of thing is going to happen, but without being able to put this evidence in place and say, okay, well, you know, when you're doing your prioritization, this is what can drop and this is what can't, we're not going to get very far with sustainability. Sorry, that was a little bit of a rant, but I feel strongly about it.
Perfect. It's exactly what we were hoping to come out of these kinds of dialogues. Shivani, I see your hand is up.
Yeah, I agree so much with what both Suraj and Debbie have said. And I think we've been doing quite a lot of work with one of the provincial governments in South Africa. And we really see that, like fiscally, so we've talked about the positive impact of COVID in terms of some of the change that's happened, rapid adoption of innovation. The flip side of that is that extremely fiscally constrained and the fiscal outlook isn't great. And what that means is that there is no leeway to add on spend for anything, So even if you said like, oh, this cool thing will down the line improve this and save money in 10 years time. Like that just doesn't fly, because you literally have to take money away from something to be able to do something else. So those trade-off calculations are incredibly important. So, we're a bunch of economists and actuaries and data scientists. So that's the sort of thing that we help people think through. It's like, what are the trade-offs and how do you create the budget space for this? Suraj mentioned the Uber example. So we have quite a lot of experience with that, and actually did help one of the provinces take over the funding for that themselves. So actually made it sustainable, purely from exactly the sort of thing that you're talking about. We looked at all of the costs. We looked at what would it actually release in terms of other resources in the system if they continued to fund home deliveries of medicine for particular subsets of patients. Maybe not necessarily using Uber as the platform, but taking that kind of catalytic moment of saying, okay, look, we can do this. We can deliver medicines to people's homes. Then actually, let's do the sums and see whether it's worthwhile doing. And the answer was yes, it is worthwhile doing for a subset of patients if you take all of the costs into account. Yeah, just really wanted to support the importance of the budget mindset and bringing much more of a hard-nosed, together with the qualitative and the human, but you do need the hard-nosed aspect of it as well. It's just the fiscal reality that we face.
Absolutely. Thank you for that. Dr. Fosika, I see your hand is up.
Thank you so much. While I agree with the other speakers, I just wanted to emphasize one point, that we know our health systems are challenged in terms of numbers and quality of human resource for health. We have got challenges with supply chain. We have challenges with our equipment and the diagnostics. We have challenges with information management, health information management. All those areas or the pillars of health systems are supposed to be functioning properly and in a well-coordinated manner. But what I've seen is that people, most of the times, we are very uncoordinated. That is working from the Ministry of Health. I see a lot of interventions, a lot of people bringing in, whether they are innovations or new interventions, they bring them in parallel systems. But if right from the beginning, we look at what government plans, and if those interventions are answering to those plans, then things become very easy, even in terms of sustainability. There is a word that I have always liked to hear, the word called game changer. There are always game changers. When we're preparing budgets, for example, from the ministries, there will be some other conventional budget lines. But if we can come up with some innovations, they can be game changers to almost everything that is being, how things are done. You can imagine now, this meeting possibly would have been meeting in Johannesburg, but because of COVID, there's this innovation, we are able to meet online and be able to make decisions and possibly be able to plan. So I feel like the most important thing is to look at the context in which we want to bring an innovation. The budget comes later. If it is an innovation that is answering to our questions, definitely some budgets are going to be diverted. We just heard budget lines are being diverted to answer to the COVID pandemic. But other budget lines can also be made available to answer to sustain or to fund those innovations or to take up those innovations into the health system, as long as they're going to improve efficiency and effectiveness and possibly improve accessibility of health services in the country. And at the end, prevent mortality and maybe reduce morbidity, they will be definitely be taken up accordingly. And the fundings, I can assure you, we can always get fundings for those. I'm saying this from the experience of Chipatara Fund because it answers to our questions and it was not a problem for government to take it up. Thank you.
Reactions to that? Thank you, Dr. Fosika, for that. Yes, Suraj.
So I just wanted to just reiterate the issue of what I was saying about the game changer. So if you look at Zoom, right? In the absence of Zoom, it would have been very difficult if COVID happened in the 1980s for the world. I don't know if even the internet would have been an issue with studying online, for example. But Zoom existed before COVID occurred, but Zoom was a business. And that 40 minutes free service changed a lot of people's lives. And that was a game changer. But Zoom is a business. The public benefit of Zoom or Microsoft Teams or Google is as a result of a business model. And if you look at a lot of what happens at Stanford University in the San Francisco belt, they produce academia or academic reports or papers or masters or PhDs that are intended to become CEOs. So I think the opportunity of research funding or of grant funding to fund innovative business models that have public health benefits. So it's aligned to the national strategic plan of the various countries. Tick box, done. It also has a need in the private sector. Yes, tick, done. Somebody's willing to pay for it. Tick, yes. So if a lot of those aspects need to be incorporated, because we will get to a point where certain solutions just become habit. Like Zoom is a habit for everybody, be it via Skype as the originator, be it Mr. D, then everybody shifted towards Uber Eats. I mean, with COVID, we didn't miss Nando's or KFC or going to fetch it or sitting in the restaurant because the food came to you. You had a variety. You didn't have to think about what to make anymore. That was a game changer. People could just get grocery delivery, 60-60. Delivery of groceries to your home, delivery of medication is becoming more and more a norm. So I think the opportunity, and I think where potentially the disconnect is that champions in public sector, champions in academia struggle to articulate or even support business models in a seed idea. So we're not talking about saying to Microsoft, come and supercharge us for a electronic health record system, or go to Google and say, charge us per activity, and then the bill becomes unsustainable. We're saying there are a lot of people with a lot of innovative ideas that can address important opportunities, but positioning them to say, think like a startup, think where the opportunity is, where it's a need in public sector, it's a need in private sector, and somebody is willing to pay. Find those type of opportunities, because there are lots. Zoom and Skype aren't unique. They were literally replicatable opportunities. So whatever happens in America can be adopted in Africa, adapted slightly, and it can become a very successful business model. So like Babbel tried to do, but the problem was the market or the country they were in didn't have potentially enough of a private sector model for Babbel's private sector version to subsidize the public sector patients, which is what Zoom technically does. So I just think that those are some things that people struggle with, to say, how do we take CSI funding, tax from governments, and create grants from them and funding agencies, and then try and fund or give seed capital to businesses that support social impact opportunities. But that is actually the better way, as opposed to saying, here you go, can you tell us how many babies had stunted growth, which is important. I'm just trying to illustrate the problems with early childhood development as a big opportunity. But the problem was, where's the sustainability aspect of it? Because if it's not a key deliverable for public and private sector, you're going to struggle to find sustainability. I've worked with somebody that's done this really cool AI. I don't know if you guys deal with artificial intelligence, or AKA fancy reporting algorithms. And this girl built this autoscriber. It takes natural language speech between a patient and a doctor, and it transcribes it. Now, that's not unique, because that happens on YouTube. You can follow somebody's video and it'll transcribe it. But healthcare conversations is very unique. But her problem was, who's willing to pay for it? I was like, it's a brilliant solution. Imagine if I get sued by the patient because I didn't pick up, there was a lump on her breast. But during my conversation, my note said, no lump on breast, or I just forgot to say lump on breast. Whereas the record would have been there because it was a direct translation of what was said. It's a brilliant solution. But I was like, where's the business model? So just to articulate the opportunity there, that we must try and look at it slightly different. And it's very, very difficult, because people feel that they don't want to share public resources, tax money, to support business development. But ultimately, you can't sustain any social digital health opportunity without there being a ROI.
Thank you, Suraj. I'm also keeping an eye on time, and I just want to give Barwani and Debbie an opportunity to make their comments before we wrap up. Barwani?
To just add on to what Suraj was saying, actually in our work, we become slightly unpopular because when an innovator comes on the table, because we usually do the research side of them and try to link them up, we usually ask to say, it's great, we've looked at it, but how is the sustainability going to be like? What is the business? And of course, Malawi is a very different context and climate when you're looking for resourcing and money, but I think that is a key question. And also, even from Dr. Fosiko's side, you find that if you talk to any government member now, they'll start asking you to say, then so what? What happens? I mean, it sounds great, you have everybody backing you. So I think now it's become a key question that everybody's getting challenged, but we also know that it's a journey, I think, trying to figure out the blended financing options that might work. and that, yes, it's a social good, and sometimes you can't call social good, but you can find an element around it that works. So I think it is a complex question, and depending on context, it could be easier, it could be harder, but I feel like as we're doing this conversation, it's something that should always be front and right to say, your impact versus the sustainability and need and cost effectiveness. Where is that? If somebody can't really say that, even if it's a brilliant idea, it can't really carry forward. So I think those are things to definitely always keep close to heart and keep checking against it. Otherwise, it's still just going to be a loop and the same things will keep popping up.
Yeah, very true. Very true. Thank you for that, Bawani. Debbie?
I have to go in 1 minute, so I'm going to keep it short. I just want to put one little challenge to Suraj's passionate plea around business models and sustainability. WhatsApp still hasn't made a profit. It's one of the most successful companies in the world and has never made a profit. For the first 10 years, it didn't make $1 profit. It is not a sustainable business, but people see the potential in it. I think we need to be a little bit careful of some of the examples we use to, because there are also examples in the business world, in the for-profit space, where there is investment pumped in from all over the place into these products, which make them as successful as they are, but they are on the basis that they could be a business model in the future. And some of them 15 years down the line have never actually seen that and are still getting billions of dollars pumped into them. So just not all roses necessarily, and not all sustainability on that side.
Yeah, it's very, very true. Thank you. I think a reminder to keep, your eyes on both sides of the coin a little bit. It is now exactly 6 o'clock. Thank you, everybody, for staying on for much longer than promised and for this really fantastic discussion. Really appreciate it. All the different viewpoints. It was really stimulating. In order to let you all off on time, I will be sending out an email with next steps and what to expect and a link to the recording as well so that you all can have that. But great conversation. Great to see you all from across Africa. Thank you for your time, and enjoy the rest of your evening. Thank you.
Bye-bye.
Bye-bye. Thank you.